Action.
Dear students, in this module, we will be covering various factors responsible for recent mortality decline in developing countries. The major learning objectives of this module is to learn about factors responsible for decline in mortality in developing countries, which will be presented with a brief introduction, followed by medical health factors, socio-economic factors, various factors that are influencing decline in mortality in India. At the same time, we also discuss about various factors responsible for mortality decline in some of the African countries, mainly to show that how these factors are contributing for the decline in mortality in various developing countries. Mortality decline in developing countries have different concepts than in that of developed countries. Among the developing countries, pace of decline is quite different from country to country. For instance, various developing countries like in Asia, Africa, Latin America, China and other South countries, except in Japan, we can see various factors how they contributed for the decline. There are various explanations for the mortality reductions which are attributed mainly through three phases we can understand. From the period mid-18th century to the mid-19th century, improved nutrition and economic growth played a larger role, as did emerging public health measures in this period. From the mid-19th century to the early 20th century, the delivery of clean water, removal of waste and advice from personal health practices all led to reducing mortality rates, and through urbanization they had though it has an opposite effect, but due to high mortality rates that are noticed in various cities. Since the period 1930s, mortality reductions have been driven primarily by factors like advancement in medicine, first through vaccination and innovation of antibiotics, and later by the expensive and intensive interventions that characterizes modern medicine, as brought out by David Cutler et al. And NBER working paper 11963. Though differences persist, many developing countries have recently experienced large improvements in life expectancy. In countries like in India and China, if we talk about life expectancy, which has risen by 30 years since 1950, even in African continent, life expectancy rose by 13 years from the early 1950s until the late 1980s, when the spread of HIV or AIDS reversed the trend. The reductions in mortality attributed to changes in income, literacy, especially among women, and the supply of nutritive calories, as well as public health interventions such as immunization campaigns, improvements in water supply and the use of antibiotics, all have contributed in reducing the mortality to a drastic level. Although it seems logical that economic growth should improve health, some of the researchers have pointed out that the evidence for this is in a mixed way. The rapid decline in mortality, as experienced by many developing countries after the Second World War, they have been largely due to public health and disease control measures, which were imported mainly from various developed countries and therefore have been independent of economic development. Among these countries, decline in mortality and the factors responsible for that decline are quite different and distinct. However, researchers made attempt to classify these factors into broad groups such as medical and health factors and socio-economic factors. Further, development of technological advancement, especially in medical science and public health, have brought various advantages in the prevention and control of disease, of the growth and expansion of public health, and medical services are also considered as major factors which were responsible for decline in mortality in most of the developing countries. In the developing countries, the decline in mortality is observed to be independent of economic development. The decline mostly attributed to transformation of medical and industrial technology from developed countries that are already existing, such as invention of vaccines, antibiotics, steam engines, radio and development of communication systems such as telephone, telegraph, etc. Various medical and health factors are also have to be noted in this regard. For instance, in the field of medical science, most important discoveries like insecticides like DDT, antibiotics like penicillin and vaccines like BCG, because of improved communication and cooperation from various developed countries, introduction of mass public health programs have greatly helped the developing countries to control various communicable diseases that they are experiencing. One of the remarkable examples of post-war mortality decline is due to public health measures is in Ceylon. Many researchers examined the decline in mortality in Ceylon, which is primarily during post-war period, and created the malaria eradication program, which introduced DDT spraying to distract malaria carrying mosquito, which has greatly acknowledged. The researcher Newman, for instance, in 1965, who has critically analyzed the relation between malaria eradication and population growth in Ceylon, has brought out clearly following points. The trends in crude death rate and natural increase of population in the country are mainly due to the intensity of malaria, and during 1946, with the widespread of malaria eradication program through DDT, the fall in the death rate was highly correlated with the intensity of malaria prevalence in the district of Ceylon. And the third is that natural increase in population in the absence of anti-malaria measures, malaria control with DDT after period of 1946 accounts for a major 60% of the population rise in the country. The reappraisal of the decline of mortality in Ceylon with special reference to the effects of malaria control after 1945 was brought out by Gray R.H. 1974, has mentioned clearly that before the Second World War, there was an association between the level of mortality and the prevalence of malaria with respect to various districts in Ceylon. His regression model revealed that there was a rapid decline in mortality during the post-war period, which was associated with an island-wide malaria control campaigns. From a regression model correlating the proportional decline in district mortality with the prevalence of malaria, it is estimated that the malaria control program contributed approximately one-third, around 23% to the decline in the national crude death rate, and malaria control was the major factor which was contributing for the elimination of pre-war variation at district mortality levels. Fredrickson 1966, Megama 1967 argued that the development of economy and level of living were quite responsible for mortality decline in Sri Lanka during period of 1943 to 1946. Selvaratnam in 1970 argued that in addition to the anti-malaria campaign, the widespread use of drugs and antibiotics to control endemic diseases have immensely contributed for the decline in mortality during the post-war years. In other country, for instance in Mauritius, post-war decline in mortality was not only due to eradication of malaria, but also improvement in environmental sanitation and progress of sugar industries. In Latin America, the decline in infant and childhood mortality has been linked to the expansion in provision of prenatal care for services for mothers and postnatal care services for infants, to campaigns against diphtheria, whooping cough and malaria, and supply of safe water supply for over 90% of population. It serves very clear that with the introduction and increased use of antibiotics such as sulfa compounds and penicillin are believed to be having a significant impact in preventing mortality, especially from diseases like pneumonia, other respiratory diseases and typhoid fever, and a large group of enteric diseases, as clearly brought out by authors like Grace, Wagner and Moldin way back in 1956. Besides these, there are broadly socio-economic factors also have to be responsible which are require of our attention. The various socio-economic factors which have been identified are proper housing conditions, water and sanitation conditions within the house, per capita income, GDP, etc. Taylor, for example, Taylor and Hill 1967 argued that the decline in mortality during early 19th century in developing countries have been attributed to general economic and nutritional development. It is very important for us to understand how the various socio-economic factors operates at different socio-economic settings in among the various countries. For instance, Fredrickson in 1966 made an attempt to know whether the reduction in mortality as a consequence of improvement in the level of living have any influence in the reduction. In analyzing the data for Ceylon, Guyana and Mauritius, he found a close correspondence between trends in the death rate and an improvement in the level of living, which is a proxy variable used for economic conditions. Robinson analyzed the Pakistan data to understand the various factors that are contributing for acceleration of mortality after 1950 and concluded that interrelationship of socio-economic and medico-environmental factors is a complex phenomenon. The rise in life expectancy in Puerto Rico during 1920s to 1940 from as high as 938 to improve further of 46 was a resultant of effect of public health and sanitation measures that are adopted by the government of Puerto Rico. Kusakawa way back in 1967 in his research on socio-economic factors in mortality in developing countries described that the effect of urbanization, literacy, energy consumption, non-agriculture activities and income have contributed immensely to 1/2 of variation in expectancy of life in developing countries and 1/3 variation in life expectancy due to variation in health services. Now, let us discuss about in Indian context what are the factors that are contributing for the decline in mortality. As we know, the death rate in India, which has significantly declined from as high as 27.4 per thousand in 1941 to 1950 to as low as 10.8 in 1986 to 91. This decline in death rate can be attributed into three main factors. What are they? They are control of famines, expansion of medical facilities, decline in infant mortality. Control over famines, for instance in the Bihar famine and the Bengal famine way back in period 1873 to 1874 was a very famous as the famine in British India, which followed a severe drought in province of Bihar, the neighboring province of Bengal, the northwestern provinces and Oudh contributed to a great extent to high deaths. The northern part of Gujarat in North India and the southern part of Rajasthan is often drought affected owing to scarcity of rainfall. That is why Tharp desert has been created there. In southern India, Rayalaseema and Telangana in Andhra Pradesh, Marathwada in Maharashtra, the northeastern part of Karnataka and the district of Kalahandi in Orissa, they are mainly attributed as drought affected areas of the country as the resulting mortality in these places are very high. An estimated 1,66,000 people died and in the entire Bombay Presidency a total of 4,62,000 were expected to have experienced mortality. In the Presidency during the famine of 1989 to 1900, which had the highest mortality at 37.9 deaths per thousand, was well noticed. Among all famines and scarcities there between 1876 to 77 and the period 1918 to 1919 were well noticed. According to 1908 estimate of the Imperial Gazetteer, in the British administered districts alone, approximately 10 lakh individuals died of starvation or accompanying diseases. In addition, as a result of acute shortage of fodder, cattle in the millions also perished. Other estimates vary between 1 million and 4.5 million deaths which are attributed during this period. However, after 1921, particularly after independence, expansion of transport facilities to rural areas, proper mobilization of food grains and import of food grains to meet domestic demand and reduced the occurrence of famines are well noticed. The other important aspect is the expansion of medical facilities. In recent years, rapid advancement in medical technology has been found to be closely observed in the field of medical science. Further, there has been expansion of medical facilities and public health services to control various diseases. Uses of various modern medicines which have controlled deadly epidemics like cholera, plague, malaria and influenza are to be noted here. Consequently, the death rate has significantly declined during these periods. The other contributory factor for mortality decline is the decline that occurred in infant mortality. An important factor contributing to low death rate is the decline in infant mortality. For instance, the infant mortality rate, which was as high as 218 per thousand in 1916 to 20, had come down to 58 in 1989 and further to around 44 in 2015. Expansion of medical facilities and better child care at maternity centers have all resulted in decline in infant mortality. All these factors have significantly lowered the death rate in India. Then let us look at what are the factors contributed for mortality decline in some of the African countries, because they are also most of the developing countries are located in Africa. It is worth for us to analyze the situation in an African region. Despite the remarkable advancement in medicine, technology and economic conditions in developed and developing countries which have contributed to immensely to increase in life expectancy, still mortality conditions in African countries remains at high during post-war and also in recent periods because of unsatisfactory sanitation conditions, food shortages, spread of HIV and AIDS and malnutrition. These are individually or collectively or contributing for high mortality situation in these countries. In African countries where long-term series of data were available, there is a consistent evidence that the mortality decline started well before 1960. A number of estimates of child mortality suggests that current levels reflect long-term and substantial changes over a period of time. The earliest estimate of SQO for Kenya, for example, goes back to 1947 when it was 262 as brought out by Hill 1991. By 1970, the probability of dying before age 5 SQ0 had decreased to 165 and it was further estimated to decline by 100 in 1985. The estimate of 5Q0 for Ghana, for instance, in 1935 was as high as 371 as brought out by Hill 1991 and it has further declined to 185 by 1970 and continued to decline, although more slowly, and it has come to 160 in 1985. Senegal, another African country, also shows a large decrease in mortality, although the current levels remain fairly high. The probability of dying by age 5 was estimated to be as high as 373 in 1946, which fell to 285 in 1970 and was estimated to be around 190 in 1985 in Senegal. The acquired immune deficiency syndrome epidemic, which is a new factor influencing infant and child mortality, was widely noticed in sub-Saharan Africa. AIDS epidemic will have both direct and indirect effects on infant and child mortality. The direct transmission of the human immunodeficiency virus HIV, which causes AIDS from mother to child, occurs primarily during delivery but may occur also through breast milk. Stato 1993 reviews simulation models of AIDS and finds that infant mortality rates are occurring more in urban areas to the extent of 20% in urban areas than in rural areas. European studies also have shown that rates as low as 13.9% in the collaborative study of European in 1991. Simple calculations provide an estimate of the order of magnitude of the effect of AIDS on child mortality in Africa, and it is estimated that approximately 2.5% of adults in sub-Saharan Africa have experienced HIV in this thing. In summary, what we observed in this is that there are several factors that contributed for the decline in mortality in developing countries like India and other African continents and African countries. Now, the factors are broadly categorized as the medical aspects versus socio-economic conditions. When you talk about medical aspects, it is very broadly seen that the medical aspects of medical innovation in the medical technology through immunization and vaccinations have greatly contributed for prevention of various diseases, especially among children, which further contributed for decline in the mortality. At the same time, it is very important for us to know that various socio-economic conditions also have immensely contributed for the decline of mortality in these developing countries. If we look at earlier periods in 18th and 19th century or earlier 20th century, the various vital rates, whether we talk about infant mortality or maternal mortality or crude death rates, all were not in favor of coming down, and they were also noticed to be at a very high levels. Over a period, thanks to importing medical technology from developed countries and also success to a great extent in public health measures and personal hygiene have to a great extent contributed in reducing. But we have to keep in mind that in most of the developing countries, in spite of not having economically advancement in the economic growth, these countries, mainly due to the importing of medical technology from the developed countries, have greatly contributed in reducing the maternal mortality and infant mortality overall by bringing down the mortality rate in particular. So, the development, whether it has occurred or not from economic terms, immaterial of that, these developing countries are showing in a reduction of mortality thanks to the importing of medical technology from the developed countries. Whereas, it is very clear that the HIV and AIDS, especially that are noticed in most of the African countries, have immensely contributed for the high mortality, especially among the working age population. Whereas, in the case of the socio-economic factors like proper housing, proper drinking water supply, proper arrangements, access to proper health facilities, they all have contributed, whether individually or collectively, in reducing the infant and maternal mortality and also contributing for overall reduction in the crude birth rate. And that is why we have to see that in developing countries it is very specific that besides importing medical technology with their own development agenda, when they have moved in terms of improving their economic conditions, in terms of their purchasing capacity, in terms of per capita income, and also in having an organized sector of employment facilities, proper housing and proper drinking water supply and other sanitation facilities, all have contributed immensely for reductions in the mortality situation, and that way there is a tremendous reduction in infant mortality and maternal mortality, which have in turn have contributed for the decline in mortality situation in developing countries. That is why when we talk about the mortality decline between developed and developing countries, it is very clear that the developed countries, economically developed, followed by medical technology and also through personal hygiene and overall proper sanitation facilities, they were able to reasonably succeed in reducing their mortality situation, whereas in the countries, most of these in developing countries, though they are still struggling with the economic development, but a positive note of reduction in mortality has been noticed mainly thanks to the importing of medical technology and also observing some of the public health measures which have drastically brought the mortality situation in these countries.